Good morning, everybody. My name is Bob Moorthy, Ramana Moorthy. I'm going to be giving you a talk today on uveitis therapeutics as it applies to non-infectious uveitis. And there's a lot of material. Much of the material that I'm presenting won't be things that you will necessarily use, but I wanted you who see uveitis patients to be familiar with those entities that and treatment options that may be available through the help of a rheumatologist, or if there is a ocular immunologist or person who's an expert in uveitis management, then that may be appropriate for them to be involved in the care of patients who require these treatments. I'm going to start by sharing the slide deck here with you. And here we go. So I've been a uveitis specialist since 1993. So I've been I practice also medical and surgical retina in the Indianapolis, Indiana area. So today we're going to talk a little bit about the treatment guidelines of systemic therapy. How do we use systemic therapy? And then we'll also talk about some of the other things like cycloplegics and nonsteroidals and corticosteroids. And then we'll spend some time on immunosuppressive agents and some of the biologic response modifiers. So the treatment guidelines start out with indications. When we have identified that the uveitis, and we already talked about non-infectious versus infectious uveitis. So now we've identified that this is not an infectious entity. So if it's non-infectious and it's causing inflammation in the eye, how do we treat this? So the indications in terms of systemic therapy are, first of all, that it has to be non-infectious, and other diseases in which an inflammatory component exists, where there's already been therapy against the infectious cause. So for example, if somebody has tuberculosis, you've already treated with anti-TB therapy, but they have persistent inflammation. In those situations, we need to consider immunosuppressive therapy, systemic therapy and or local corticosteroid therapy. But the goal of therapy is to control the inflammation and eliminate the risk to vision from structural and functional complications from uncontrolled inflammation. And for me, control of inflammation means no cells. If I can achieve that, that's my goal. That's the prime goal. No cells in the anterior chamber if it's anterior chamber inflammation, and really no macular edema, and stabilization of posterior segment disease. It's very difficult to get rid of vitreous cells, so I'm skirting around that issue. Vitreous cells may remain stable and be minimal for many years in chronic inflammation that involves the vitreous, like intermediate uveitis or panuveitis. But should improve, but you may not get rid of all the cells in the vitreous. And we'll talk about that in a second. The choice of agent is really kind of based on the specific diagnosis and whether or not there are concurrent ocular systemic diseases present and the level of functional compromise. In other words, if the patient has really good vision and has adult onset, mild intermediate uveitis with 20/20 vision and floaters, those patients may not need to be treated as aggressively, and they can be monitored in some cases to monitor for the progression of disease course. Some people with that entity may not need any treatment at all. And then a monocular versus binocular disease will kind of tell you, hey, how aggressive do I need to be? And similarly, a one-eyed patient versus a patient who has two functional eyes, in those situations also, the aggressive nature of the therapy is kind of determined. And also, of course, the patient's desires and their past experience and what they want from the treatment. It may involve everything from their ability to tolerate the side effects of the treatment to the likelihood that they're of childbearing age and they want to have children. That may also determine the kind of therapy you choose. The paradigm initially of this therapy is to control the inflammation rapidly. And then the corticosteroids are really the most effective agents, with one possible exception, which I'll cover. But corticosteroids are the most rapid way of getting inflammation well controlled, used topically, regionally, or systemically. Okay. And we'll talk about each of those things. So why do we know, or how do we know that corticosteroids are the most effective agents? The good news is that there is a randomized control superiority trials that compared systemic anti-inflammatory therapy versus the fluocinolone acetonide implant. And by systemic anti-inflammatory therapy, we're talking about corticosteroids initially, then to corticosteroid-sparing immunosuppression. And we know from the MUST clinical studies that initially at the 5-year data that there was really no difference between the fluocinolone implant versus systemic anti-inflammatory therapy. But as the study progressed and the 7-year data and now the 10-year data is coming out, we see that there may be some advantages, particularly in patients with bilateral disease, to systemic immunosuppressive or immunomodulatory therapy. So systemic therapy with aggressive use of corticosteroids sparing immunosuppression in general appears to be well tolerated, with very few long-term side effects requiring discontinuation of therapy in the MUST trial. And this is a very important trial that was conducted in multiple centers around the world, around the globe. And so this is important information for you. And this is an ongoing evaluation with the MUST treatment trial. For certain conditions, such as mild scleritis, non-steroidal anti-inflammatory agents may also be used. There are some conditions where early initiation of immunomodulatory therapy, that is corticosteroid-sparing therapy, may be considered. And this is one of those exceptions where we see rapid onset of activity, anti-inflammatory activity faster than steroids. And that's, for example, in the treatment of Behçet's disease of the posterior segment. Agents such as Infliximab or Remicade can be, with explosive onset Behçet retinal vasculitis, that can be extremely helpful in controlling inflammation very rapidly when given intravenously as intravenous infusion. So Behçet's is one of those conditions where we consider immunosuppression and immunomodulatory therapy starting early in the course and early initiation. Sympathetic ophthalmia, necrotizing scleritis with systemic vasculitis, and serpiginous choroiditis or choroidopathy, where there is sight-threatening involvement. In some cases, we may want to initiate early immunomodulatory therapy. There are other things like birdshot uveitis, juvenile idiopathic arthritis with chronic uveitis that's steroid dependent, multifocal choroiditis and panuveitis, and both Koyanagi-Hirata disease. These are also other conditions where we may consider early initiation of immunosuppression. Initially, what we do with treatment is with corticosteroids, when we start with corticosteroids, before we start the immunomodulatory therapy, corticosteroids are the mainstay. So we start at high levels. So for example, with systemic corticosteroids, we start at 1 milligrams per kilogram per day of prednisone or prednisone equivalent. So we're talking about 60 to 80 milligrams of prednisone daily. And prednisone is gradually then tapered by 10 milligrams, typically very slowly. I typically go down by 10 milligrams every 2 weeks. With initial pulse therapy of the corticosteroids. And I often, if I think that the patient has one of those conditions where we want to start early immunosuppression, I may start the immunosuppression within 1 or 2 weeks of starting corticosteroid therapy. If control cannot be achieved as you are tapering therapy, and you can't get, for example, if I can't get the patient controlled unless I'm using every 2-hour corticosteroid drops, I may be then, if I'm using drops to control anterior uveitis and they still have 2+ cells and they've been compliant with the medicine or getting the drops in every 2 hours. And that situation, I'm going to be considering, hey, I have to be more aggressive. If it's unilateral disease, I may move on to periocular corticosteroid therapy if it's non-infectious, or I may start oral corticosteroid therapy. But if oral corticosteroids themselves are failing and you cannot control the inflammation unless the patient is on 20 or 30 milligrams of maintenance prednisone, which is not good because that's associated with substantial increased risk of patients developing secondary complications from corticosteroids, including things like hypertension, secondary diabetes, and in postmenopausal women in particular, developing osteoporosis and bone loss. Then we need to be considering the initiation of second-line therapy with immunomodulatory agents. So in second-line therapy, again, a safe dose of corticosteroid is, in my opinion, probably under 10 milligrams of prednisone daily, typically 5 to 7.5 milligrams daily. That's a respectable. If you can control patients with that amount of corticosteroids who have chronic disease, that's good, and that may be required. But again, I would prefer even less than that if at all possible. And again, a lot of the decision about second-line therapy was based on even at 5 milligrams daily, if the patient is having a lot of intolerable side effects of prednisone, that may push me in the direction of wanting to add the second-line therapy. Let me back up for just a second. There is a general feeling, I think, among ophthalmologists, and I think because of the nature of the diseases that we typically take care of, that we feel like, hey, this person has already had so many weeks of therapy, they should be cured by now, and I should be able to take them off steroids. Remember that chronic diseases, unfortunately, chronic uveitis requires chronic therapy. For example, you don't treat hypertension for one day and say it's cured. You don't treat diabetes with a single injection of insulin and say, well, you're done, you're finished, diabetes is cured, it's out of your body. Well, that's a ridiculous statement. And so when I see patients where multiple attempts are made to try to wean some small amount of steroids off, and then the patient keeps getting recurrences and flare-ups, I tell them, well, you've done this for 6 months. How many times are you going to be, how many times is it going to take you for you to realize that this disease is chronic? It's not going to be going away unless you have some baseline amount, the lowest possible dose of corticosteroid that is required, whether it's topical or regional or systemic corticosteroid that may be required to control this inflammation. So second-line therapy, if even in acute or limited duration disease where corticosteroid therapy really has failed and has not worked, we may consider that. Or if the individuals are unable to tolerate corticosteroid therapy. There are multiple classes of drugs in second-line therapy. Generally, however, the randomized clinical trials are lacking. However, we have a lot of retrospective data that's very useful from the SITE studies, SITE studies, which I'll refer to in a moment. And that will help us kind of determine the selection of an agent. There are some very important studies that were done recently in multi-center studies done in India and the United States, evaluating the differences in efficacy between methotrexate and CellCept. It appears that maybe methotrexate as a second-line agent, as an anti-metabolite, may be a little bit more effective in the treatment of inflammatory disease compared to CellCept or mycophenolate morphotyl. And so methotrexate might be a very appropriate second-line agent as a corticosteroid-sparing second-line agent as a first choice of medication for an anti-metabolite. Azathioprine also is an anti-metabolite. Typically, most people have shied away from using calcineurin inhibitors, particularly cyclosporin, although some people still use tacrolimus, which has less toxicity and is a more potent calcineurin inhibitor, can be given at relatively low doses with fewer side effects. Sirolimus, as it's going to be available probably in an intravitreal injection form, shows some promise of efficacy, but it is not approved for intravitreally for clinical use, and I don't use it systemically. There are alkylating agents also that can be utilized for the treatment of second-line agents and even third-line agents. These are much more potent agents and usually are used in conjunction with a rheumatologist or more likely an oncologist, particularly with these two agents, because they're much more highly likely to, when used inappropriately, to cause secondary cancers or lymphoproliferative and leukemic disorders. So I'm sorry, the slides keep changing. I'm not sure why this is happening. And biologic response modifiers such as Infliximab, Adalimumab, and Tocilizumab are typically the three ones that I used as second or third line agents. And typically these are third line agents when methotrexate or CellCept or Imuran have failed. So this is kind of beyond second line therapy. Sometimes we use a combination. We add the third line of agents if the second line agent and the steroids aren't working. And we may use a combination of drugs. And sometimes if that's not appropriate, we may switch to surgical therapy, such as vitrectomy and pars planitis, that may be effective in help controlling inflammation. We may also use other things like implantable long-term steroid devices, such as the Retroseptal implant, which is a fluocinolone acetonide implant. Pregnancy and the desire to have children, these are an important part of deciding the immunosuppressive therapy. And of course, with vaccine recommendations, generally, and with COVID-19, it has become particularly a difficult problem to answer. But with patients who are receiving any kind of immunosuppressive therapy should probably avoid live viral vaccines. In the case of COVID-19, generally the consensus has been to go ahead and immunize those folks with COVID-19. And in fact, we're even considering a third booster dose for those who received the BNT vaccine from Pfizer or the Moderna vaccine. We're giving a booster dose for some of these patients, even in the United States. So if the patients are immunosuppressed, generally we want to vaccinate them against COVID. And I have been pro-vaccine for these folks. Generally, I tell them that we may want to hold the second-line immunosuppression agent like CellCept for a few days before the vaccine and a few days afterwards, and then resume. And then for the Humira, for the biologics, generally I will try to time the vaccine in between their dosing without having to necessarily stop that. The efficacy of these vaccines in the face of immunosuppression with COVID-19, we know, is less. And that is why if we have efficacies of between 30 and 70% as opposed to 94% according to clinical trials in healthy individuals, we may want to do that third booster on those patients. So, there are, as I was mentioning, the site studies and must clinical trials that form the basis of the decision of these agents that we use. At 7 years, here's the must study results. When we looked at steroids plus immunosuppressive therapy, there are better visual outcomes at 7 years compared to the fluocinolone implant, and with comparable quality of life and safety data. So it's safe to use systemic immunosuppressive therapy in chronic uveitis, and it seems to be long-term better than using just a steroid implant, which often has to be replaced, et cetera. Do immunosuppressive agents increase the risk of cancer mortality? The good news is that the cancer mortality, when we use based on the site studies, shows that the overall cancer mortality of using anti-metabolite medicines and the calcineurin inhibitors and corticosteroids or dapsone, these incidence rates of cancer mortality are very similar to those who have never taken these immunosuppressive drugs. So that's very good. So there's no increased risk of cancer with these agents. However, with cyclophosphamide, overall mortality was not increased, and cancer mortality was not significantly increased with cyclophosphamide. And however, there is, if you cross a threshold with cyclophosphamide beyond a cumulative dose of 35 grams, there appears to be a substantial increased risk of secondary lymphoproliferative or leukemic malignancies, particularly AML. And with TNF inhibitors like Humira and Infliximab, Adalimumab and Infliximab, there was an increased risk of a hazard ratio of around 2 of increased risk of cancer or cancer mortality. So this is important to remember that TNF inhibitors aren't necessarily the safest choice of drug, but they're often necessary. I'm going to switch gears. That's kind of the overview. And this is a long lecture, and I apologize. I will try not to spend too much time and bog down on the details of the immunosuppression. I wanted to give you kind of an overview because many of you, as I said, probably will refer these patients to a rheumatologist and or a uveitis specialist if there is one in your area. If not, I think it's important for you to know what's available to recommend to a rheumatologist or an oncologist. Hey, this is what you need to do for me, and this is what's typically done. We'll talk about the simpler things, though, the day-to-day things that we often forget or don't pay attention to. So cycloplegics are very important in the treatment of anterior uveitis. Why? Because chronic anterior uveitis in particular and severe acute anterior uveitis can result in significant edema and inflammation of the iris itself that can cause the development of posterior synechia, which can be very extensive in severe acute disease. And we want to prevent the development of posterior synechia, keep the pupil mobile, and prevent formation of new synechia. So we use this for anterior chamber inflammation. We also use it to reduce pain, photophobia, that is pain from due to ciliary and sphincter muscle spasm, and pain from exposure to light in these acute uveitis cases. And we also use it to break recently formed synechia. If the patient has allergy or sensitivity to the agent, this is a contraindication, of course. And the other thing is you always need to check for angle depth to make sure that the patient does not have primary angle, narrow angles, so that they do not develop angle closure attack on the cycloplegics. That's rare, but you can assess that when, of course, you do your slit lamp examination. I can't express to you the importance when you give me or give us information as cybersite mentors, when we're looking at these cases, when I ask you, when you give me the clinical information, telling me the amount of cell and flare in the anterior chamber under the slit lamp examination, telling me the nature of the vitreous and vitreous findings, how much cellularity there is in the vitreous, which you can assess with the slit lamp, is very important. I can't decide how to help you treat a patient unless that information is given. So many times I have information that's sent and I can't, determine based on the data that's given to me how I can help the patient or you in that situation. So I encourage all of you. I hope you all have slit lamps. Many of you may not in the field, but slit lamp examination in uveitis patient is very, very important. So the dosage of cycloplegics is kind of dependent on the severity of the inflammation. If a patient has severe hypopian uveitis from HLA-B27 positive uveitis, in those cases with a lot of fibrin in the anterior chamber and the patient may present with significant synechia formation, I will start with a very potent agent such as atropine initially, and I would use it very frequently, 4 times daily. A higher dose should be very carefully used in children and older adults because of the risk of getting secondary psychosis, atropine-induced psychosis, which I have seen in patients, not in uveitis patients, in patients, however, where I've used it as a post-operative drop after retinal surgery. Scopolamine can also be used. This is also a longer acting agent. Atropine scopolamine typically lasts 7 to 14 days after installation. Homatropine lasts 2 to 5 days. Cyclophenolate about 24 to 48 hours, and tropicamide 12 to 24 hours in duration. The most effective use is to prevent synechia formation. Really requires monitoring the pupil size and shape. And one of the things you do with the slit lamp when you look at a chronic uveitis patient is I actually tell the clock hours where there are synechia. Because in chronic disease, sometimes you think, oh, the disease is well controlled and the patient may come back in 2 or 3 months and they have a new area of posterior synechia. Unless you've documented where it is, you may not be able to tell. So this is something that you need to do. I talked about psychosis from cycloplegics, but because of their antimuscarinic effects, you can develop tachycardia, fever, urinary retention, those kinds of things. And cycloplegia, of course, induced blurred vision. So when you're using it in chronically, I tell people to take it as a bedtime regimen or once weekly regimen once the inflammation is controlled. And occasionally I will just have them stop it if they have acute disease and the acute disease is gone. Also, one thing you have to be careful about is if you use a very long-acting agent like atropine long-term, the patient sometimes develops a large fixed dilated pupil because there is posterior synechia formation and a dilated pupil, which is very problematic because it induces a significant amount of photophobia and other monocular diplopia and other complaints that may occur. So atropine may cause a widely dilated pupil that's fixed due to posterior synechia if you're not careful. Once the acute inflammatory process is under control with the atropine can be switched out to something milder like cyclopentolate, which is what I typically use. So first question that we have, poll question, which of the following agents is associated with the longest duration of pharmacological dilation of the pupil? Tropicamide, scopolamine, cyclopentolate, or homatropine? So let's see if you guys were paying attention. I mentioned it. So, okay, not so good here. So yeah, scopolamine is like atropine. It lasts 7 to 14 days, okay? So it's a very long-acting cycloplegic agent. Home atropine is about 2 to 5 days and 5% home atropine. So scopolamine is a longer acting agent. Cycloplegic induced psychosis is most likely to occur in which age group? Pediatric, young adult, elderly, or late teens? We just kind of briefly talked about this. This is more to see if you guys are paying attention. Okay, so the right answer is pediatric. So most of you got that right. That's good. Non-steroidal anti-inflammatory agents can be utilized for the treatment of very mild scleritis and episcleritis. Even topical NSAIDs may be of benefit for very, very mild episcleritis because episcleritis is usually just a red eye with no pain. Scleritis, on the other hand, often requires systemic therapy and sometimes local therapy in carefully selected cases. It may be useful as a steroid-sparing agent, according to some studies for JIA-associated uveitis that has not, and HLA-B27 disease. I have been cautious in interpreting the data from the study that suggested this, but there is probably some role for a very, very mild disease where you don't need necessarily immunosuppression, but but you can use this as an option for adults or even some children. And it can also be useful, of course, with postoperative cystoid macular edema or pseudophakic patients who may have uveitic macular edema. You can use topical NSAIDs like ketorolac or bromfenac or nepafenac. Those are agents that are readily available these days. There are some contraindications to systemic nonsteroidals, patients who have renal insufficiency or peptic ulcer disease or allergies or have underlying bleeding disorders. There is some potential risk for COX-1 inhibitors that we know of for causing, cardiovascular and thrombotic disease. So we have to be very careful about that. I apologize for my cursor. I'm not sure exactly why the slides are skipping. I don't think I'm doing anything wrong with this, but I'm not sure why this is happening. The other things that complications can include gastric and peptic ulcers with nonsteroidals given systemically. Remember that the increased risk of gastric and peptic ulcer disease occurs when nonsteroidals are combined, in particular with systemic corticosteroids. But systemic corticosteroids alone probably have less risk of inducing peptic ulcer disease compared to nonsteroidals alone. And certainly nonsteroidals combined with corticosteroids probably have the greatest risk, about a 20-fold greater risk than corticosteroids alone or nonsteroidals alone in causing gastric or peptic ulcers. So that's very, very important to keep in mind. Occasionally, you may see liver function abnormalities and clotting disorders with these agents. In topical nonsteroidals, you can absolutely see corneal epithelial breakdown and thinning. So some patients are particularly prone to having really severe keratopathy and toxicity from nonsteroidal use. So be careful when you put patients on this. You need to monitor them carefully to make sure they're tolerating it early on. I have had some patients that developed very severe corneal thinning on nonsteroidal therapy that did affect their vision very, very badly. And that's rare. I have maybe 1 or 2 patients in all the thousands of patients that I've treated with these agents, but it's very important to keep in mind. It can delay wound healing and cause conjunctival hyperemia in some cases. That's kind of counterintuitive, right? Because we use it to treat episcleritis, but it can cause conjunctival hyperemia. So here's a question that I'm going to give you on which of the following is most likely to induce peptic ulcers? Systemic steroids, and systemic non-steroidal anti-inflammatory, systemic corticosteroids combined with NSAIDs, or all are equally likely. We just talked about this literally 2 seconds ago. So yeah, so you got it. So combined systemic corticosteroids and NSAIDs are really that's when you're at greatest risk, probably 20-fold greater risk than either agent alone. So you have to be very careful and probably use H2 blockers or other agents, PPI inhibitors when patients are using the combination of steroids and non-steroidals in particular. So corticosteroids, we already touched on how when we use them for non-infectious uveitis or infectious uveitis as an adjunctive therapy combined with antimicrobials, or diseases where there may be the primary etiologies has been treated, but there's still an inflammatory component. So contraindications are infectious etiologies, and there are several kind of caveats to this. So if a patient has for topical corticosteroids, if the patient has an infectious keratitis with epithelial breakdown, you should not be using topical steroids, okay? If the patient has an infectious herpetic retinitis, syphilitic uveitis, that is untreated with antimicrobials, tuberculous uveitis that's untreated with antituberculous therapy, those patients should not be treated with corticosteroids alone until appropriate antibiotic coverage has been given and for appropriate periods of time. And if the patient has poorly controlled diabetes, that's a significant contraindication, especially a brittle diabetic who's insulin dependent. Those patients can be thrown into a non-ketotic hyperglycemic coma from corticosteroids. Blood sugars can go up to 600 to 800 milligrams per deciliter. So very, very high levels of sugars. And of course, if the patient has very severe peptic ulcer disease or erosive gastritis already, and then, when you have non-steroidals already being used, concomitant use of corticosteroids increases the risk of this peptic ulcer disease. And corticosteroid-induced intraocular pressure elevation may be a relative contraindication if you know this, especially if the patient has severe underlying glaucoma. There are numerous topical preparations of corticosteroids. Difluprednate is very potent. It's twice as potent as prednisolone acetate. Difluprednate also has a substantially greater risk of steroid-induced ocular hypertension and glaucoma, and also has a greater risk of causing steroid-induced cataract. And particularly in children, there is a potential that in difluprednate, 50% or more of children will, on topical difluprednate, develop steroid-induced ocular hypertension. And I believe that this is a great drug to use acutely, but not a good drug to be used for chronic maintenance therapy. It's very difficult to leave a patient on chronic maintenance difluprednate and expect that their intraocular pressures are not going to go up. With any corticosteroid, with long-term use, topical, regional, systemic, any of those can cause intraocular pressure elevation at any point during the course of treatment. In fact, a periocular corticosteroid injection in rare cases has been shown to cause intraocular pressure elevation years after it has been given. And it's thought that these patients may have some underlying predisposition to developing glaucoma or high pressures, and the steroids throw them over the edge. So I think it's very, very important to monitor the intraocular pressures, even in stable patients, in stable chronic uveitis. The longest interval I go between examinations typically is 4 months. And that's because I have had patients at the 6-month interval develop dramatic glaucomatous optic discupping intraocular pressure ablation when they've been stable for years. And I kick myself in those situations where that happens. And some patients have lost a lot of vision as a result of that. So I am very, very cautious, even with topical corticosteroids being used as maintenance therapy as low as 1 time daily. And I rarely use Durezol as a maintenance therapy. It's great for acute control, but not so good. So other agents that are milder, I tend to use Durezol as my initial agent for severe disease, prednisolone as my initial agent for milder, and then step down therapy to prednisolone if I use difluprednate initially. And then finally, fluorometholone is my third agent. I don't use prednisolone sodium phosphate. I just don't think it works as well. It doesn't penetrate the cornea as well, in my experience, and get into the anterior chamber. I do not use topical dexamethasone because of its intraocular pressure issues and its efficacy. And Remixolone is just for us I don't use it. It's not available for us, and most of our insurance carriers don't cover it. Local injections of corticosteroids we've alluded to, but triamcinolone is the typical agent that I use. It's a depot steroid that's given either subconjunctivally or in the posterior subtenon space. It lasts for several weeks, and it can be given as frequently as every 2 to 3 weeks, but typically I give it monthly if I'm going to give it repeatedly in an eye. This is considered particularly useful in unilateral disease, unilateral chronic disease, or unilateral acute severe disease, because the patient doesn't necessarily need systemic therapy, but needs more than topical drops. Intraocular corticosteroids, I am very cautious about their use in uveitis initially. I typically will use this in selected cases where there's foveal threatening inflammation, such as foveal threatening serpiginous choroiditis responds very well to intravitreal triamcinolone. And the risks include a substantial risk of intraocular pressure, elevation, and cataract formation with repeated use. There are some patients who are not tolerant of steroids given systemically, and intraocular steroids are the only way you can control them, but they come with substantial risk with repeated use. Of course, intraocular antibiotics and intraocular anti-VEGF inhibitors are used in selected cases for uveitis-related complications and in infectious uveitis, of course. There are periocular, other periocular preparations such as depomedrol that are used, and shorter acting agents that betamethasone and so forth that I rarely, if ever, use. There are many ways to deliver regional corticosteroids. I typically will give a posterior subtenons injection. This is a patient of mine where I'm having her look down and in, and I give it in the superior temporal quadrant. I will use the lacrimal gland as a kind of a guide to where I put the needle entry just anterior to the edge of the anterior edge of the lacrimal gland, the palpebral, the orbital, the palpebral lobe of the lacrimal gland, and very gently use a sweeping motion as described by Dr. Robert Nozick many years ago, using a short 5/8 inch 25 gauge needle with a 3 cc syringe. I use a 3 cc syringe because the plunger does not have to be so far back compared to a tuberculin syringe. My hands are fairly short and small. So, and it's convenient. I know I've gotten the feel of how that is supposed to feel as I inject. I have seen complications from this that can be devastating. I have seen 2 patients that I performed periocular corticosteroids that developed intra-arterial embolization of the corticosteroid. One patient who has orbital disease, that with orbital, she had a severely inflamed sarcoid-related inflammatory lacrimal gland and orbititis, and I gave her a corticosteroid injection after an orbital biopsy surgery. And the patient developed intraarterial embolization into the choroidal vessels as well as the retinal vessels and became NLP. The patient fortunately recovered completely to 20/20 vision. About a week later, I gave her intensive corticosteroid therapy, emergent paracentesis, and was able to move most of those corticosteroid particles, and there were very few. I've had another patient, unfortunately, where that happened to, where she lost most of her vision and did not recover. So that can happen. So I always retract the plunger once I've gotten to the point I advance it to the hub of the needle and retract the plunger to make sure there's no blood that comes back and make sure there's not much resistance. If you feel a lot of resistance, you're in the wrong spot. You may be near a vessel. You may be in a position where that, and the bevel of the needle is always pointed down towards the globe as I'm advancing. If you don't feel comfortable with this, and many people don't, the other approach is to do a retroseptal approach with a short 27 gauge needle, a 27 gauge needle and a 3 cc syringe, and then you go directly, you go transcutaneously, and this is very well tolerated with the 27 gauge needle. I would not use a 25 gauge needle here, that's more painful, and go directly, feeling the margin of the globe and just staying just below the globe and go directly through the orbital septum, perpendicular to the orbital septum, just inferior to the globe. There are complications with both of these techniques. You can see ptosis develop with this technique, with the posterior subtenon technique. The retroseptal technique, you can see orbital, you can see festoons, orbital festoons develop, and the subcutaneous orbital fat prolapse. The oral agents typically that I use are prednisone. I alluded to this earlier, 1 milligram per kilogram per day starting dose, and then gradually tapered. With the topical steroids and with oral prednisone, the idea, the paradigm of treatment is to start at high doses and gradually taper. Okay, most episodes of inflammation, like it or not, well, you may disagree with this. This is just an observational thing. So, for example, HLA-B27 disease, anterior uveitis lasts 12 to 16 weeks. So if you're tapering these patients off in 2 weeks, they're going to recur. So be careful. I would rather overtreat an acute episode and monitor the patient and gradually taper them off than for them to have a recurrence, which will become a recalcitrant to therapy and then become chronic. And that happens often in HLA-B27 disease. So it's very important to remember that and keep that in mind. So oral agents, or prednisone is typically what I use. Intravenously, you can give methylprednisolone for the most severe diseases. We used to use, for example, explosive onset Behçet's or severe BKH disease. I will use high doses of IV steroids for 3 days and then transition to oral corticosteroids. Patients often needed to be admitted to the hospital. Sometimes we can do this outpatient, but the blood pressure and blood sugar should be monitored very carefully when you're giving intravenous therapy in these agents, with these agents. There are complications, ocular complications from steroids of any form, include posterior subcapsular cataract and intraocular pressures. With systemic use, there are many short-term complications, including weight gain, mood swings, acute hyperglycemia, manifestations of latent diabetes, where you may have a person who has glucose intolerance that becomes frankly diabetic, exacerbation of hypertension, fluid retention, worsening of congestive heart failure, potassium loss, hypokalemic alkalosis, and hypertension. All these things are risks. Patients who receive high doses of corticosteroids over 60 milligrams a day may be particularly at risk, although idiosyncratically, for the development of aseptic necrosis of the femoral and humeral heads, a devastating complication that is rare, but can definitely happen with higher doses. I have seen it with corticosteroids. So if a patient develops hip pain on a high dose of corticosteroid therapy, the corticosteroid therapy probably needs to be stopped fairly rapidly, and the patient needs to be referred to an orthopedic or specialist and to have an MRI of their hips to look for aseptic necrosis. There may be other things that are common, many different side effects, every possible systemic side effects associated with the human body, as I think has been reported with corticosteroids. If you have infections that are untreated, they can get worse on steroids. Long-term use, osteoporosis in postmenopausal women, especially begins to develop within 3 to 4 months of corticosteroid systemic therapy. So once the patient is on maintenance steroids, annual bone density studies to look for osteoporosis is very important. There's impaired wound healing with chronic corticosteroid use. You can develop many other problems, everything from fatty liver to chronic pancreatitis, peptic ulcer disease, etc. You can reactivate latent tuberculosis when inappropriately or inadequately treated TB may be present in patients that in TB endemic areas in particular. Pathologic fractures of long bones, fat redistribution, and the development of the humpback and Cushingoid features from chronic steroid use are well known. Regional corticosteroids, I already told you about injections of the retinal cortical circulation, perforation of the globe that can be done that can occur in hypotenuse eyes in particular. It can occur with retroseptal as well as posterior subtenon injection. I have seen both, and I've done one, fortunately with a happy outcome, but it can be very, very significant, can create significant problems. So be very, very cautious in patients. Ptosis and proptosis, we all talk about orbital fat prolapse. We talk about patients can develop subconjunctival hemorrhage with the injection. A periorbital hemorrhage can occur as well. Although corticosteroids, when given in the periocular space, don't typically cause systemic problems, they still do get absorbed systemically. So they can affect blood sugars. They can affect blood pressure in some patients who are prone to having problems. So intravitreal corticosteroid implants like Retroseptal or the Utique, for example, that are used for the treatment of uveitis and uveitic cystoid macular edema, last for a long time. And Retroseptal in particular is associated with cataract formation within 2 years after implantation in 100% of patients. So cataract will occur in 2 years, guaranteed. And 40% of patients may need surgical intervention for glaucoma. 50% will need glaucoma with topical medications with these sustained release implants, particularly this is mainly referring to Retroseptal. Similar data, although less severe, has been reported even with the Utique implant, Utique brand of low-dose fluocinolone acetonide implant. Vitreous opacities and vitreous hemorrhage are very common postoperatively, and these usually spontaneously resolve. Endophthalmitis is a potential risk because you're doing surgery, and conjunctival erosion of the anchor suture can occur with the Retroseptal implant. And, again, with Retroseptal implant, you have to start managing their immunomodulatory therapy and corticosteroids and start tapering them and get them off these agents relatively rapidly once you get them on once you start doing once you've done the Retroseptal implant placement. Retroseptal implant, by the way, the retail price in the United States is $19,000. It is very difficult in private practice to have a surgery center obtain this. So we often have to fight with the insurance companies to get this approved before a patient can get this implant. It is still a product that has a role to play in the management of chronic uveitis and posterior uveitis in particular. We already talked about many of these other things. External infectious disease in the conjunctiva is a contraindication to topical corticosteroid use. Some patients with topical corticosteroid use chronically can develop recurrent subconjunctival hemorrhages, which can be a nuisance for the patient. You need to monitor these patients carefully. We've already talked about some of these monitoring issues. Next question. If a patient was treated with, I'm sorry, I can't see the question. Prednisone 60 milligrams daily for a week for uveitis, and the prednisone dose was tapered and discontinued over a 6-week period thereafter, which of the following complications of corticosteroids would be least likely to occur during this period of treatment? Weight gain, aseptic necrosis of the hip, hypertension, or mood disturbances? We touched on this. This is a little bit more difficult question. So let's see what you've come up with an answer. So you're right. Aseptic necrosis of the hip is pretty uncommon. It's a severe and devastating problem, but it's very idiosyncratic. And it occurs usually in patients who are receiving more than 60 milligrams a day, but in high dose therapy. All right. So the following tests need to be performed for patients on maintenance therapy of oral prednisone of less than 10 milligrams daily. Monthly SGOT, SGPT liver function tests, monthly BUN and creatinine, annual complete blood count, or annual bone density scan. When you're on maintenance corticosteroids, we talked about this as well. Especially in postmenopausal women, we worry about what? That's right. Most of you got it. That's excellent. So you worry about osteoporosis. So you want to do an annual bone density study if it is available in your community. So we'll move on now and talk about the second line agents beyond corticosteroids. So let's say that you've got the patient, a patient who has bilateral, and we'll make it simple. I don't want to, there are many exceptions to all of these. I want to kind of, I don't get bogged down on the details here. They have bilateral chronic inflammatory disease. You can't go below 20 milligrams of prednisone before they start flaring up. They have chronic cystoid macular edema. It's just not responding to steroids alone. They also are developing a cataract. They have intraocular pressure problems, and you need to do something to get them off. So what are your choices? My first choice is usually to go to an anti-metabolite. Methotrexate may be my first agent, or although for me, it has been personally for the last 10 years, I've been using mycophenolate morphotyl for the last 15 years. Mycophenolate morphotyl, usually 1 gram BID to 1.5 grams BID. That's a total dose of 3 grams per day. And then the other possibility is starting at a relatively moderate dose of methotrexate and increasingly rapidly based on response. One couple of things we'll talk about each of these agents. If these fail, I sometimes will then move on. Well, I'll add a TNF inhibitor these days. because of the data results, which we'll talk about from the visual studies, Visual 1 and Visual 2, which are beautiful studies that actually probably are the cornerstone of great clinical trials, in my opinion. They were really well done because I think the uveitis specialists that were involved with this and to design these studies really had a great idea on how to conduct these trials and really understood uveitis. So, there are some patients who are treated for mild ocular cicatricial pemphigoid. They can be treated with non-steroidal medications like dapsone or sulfasalazine for mild OCP, but corticosteroids are really the first-line therapy. We talked about second-line therapy as being anti-metabolites and then other things. And then third-line therapy is usually anti-TNF therapy, and in some cases, Rituxan. So the mechanisms of these anti-metabolites in particular are really directed towards interference with cell division, particularly with inflammatory cell division directed towards inhibition of T cell replication. And that's where the target really is. They're broad, right? They're given orally, so they affect all the cells that are dividing in the body, but their most profound effects we see are typically going to be as a result of their effects on inhibiting T helper cell replication, which is one of the fundamental concepts of uveitis, autoimmune uveitis or non-infectious uveitis development. So we have, these agents. The steroids work at the level of the antigen presenting cell, as also at the cell nuclear level in terms of transcription, translation, and as with the cyclosporin and tacrolimus are calcineurin inhibitors that subsequently can affect replication, DNA replication, and transcription and translation. And then mycophenolate and azathioprine, and to a great extent also methotrexate, those are inhibitors of the cell cycle. And we'll talk about methotrexate a little bit more in detail, but the mycophenolate and azathioprine in particular are purine synthesis analog or inhibitors, and they have a specific role similarly in inhibiting T helper cell proliferation. So when I start immunomodulatory therapy, I will typically get a complete blood count and liver function tests and a metabolic profile on patients. If I'm using azathioprine, I used to check for thiopurine methyltransferase activity because there are heterozygous and homozygous mutations for this particular enzyme that can cause liver toxicity from azathioprine. Although this is a very expensive test, I sometimes do it, but I will usually start at low doses of azathioprine and monitor liver function tests very closely, because you're going to be able to tell fairly quickly within a few weeks of therapy how the patient's going to respond and whether they have a heterozygous or homozygous mutation for TPMT. The routine monitoring initially, once they start immunosuppressive therapy with anti-metabolites or alkylating agents, is CBC and liver function tests at least monthly initially. And then once they're on a stable dose, every 2 to 3 months or less. And often I'll have the internist and or rheumatologist follow along with me. I prescribe my own anti-metabolite and anti-TNF therapy for Humira. If I need infusion therapies, Rituximab, or if I need chlorambucil, I may rely on rheumatologist or an oncologist, particularly for chlorambucil therapy. There's special consideration, fetal risk consideration for immunosuppression. So there are certain drugs that are allowed during pregnancy. Glucocorticoids or corticosteroids are allowed. Azathioprine and 6-mercaptopurine are allowed during pregnancy, and TNF inhibitors are allowed. So in childbearing age, those are agents that may be more safe to consider. Cyclosporin and tacrolimus also have been used during pregnancy, and they have relatively low maternal and fetal risk. But moderate fetal risk and harm, of course, is with cyclophosphamide. Methotrexate is moderate to high risk because it's a category X medication, was originally an abortifacient. So it is not something that you want to use in childbearing years, and unless the patient is practicing 2 forms of contraception. Mycophenolate Morphotyl similarly, leflunomide similarly, this is rarely used. This is an agent I rarely, if ever, use. And then, of course, in the third trimester, use of aspirin and nonsteroidals, you have to be careful. There are certain unknown risks during pregnancy, specifically the Rituxan and some of these other agents. Tocilizumab, we don't know. So let's switch to anti-metabolites. We'll talk a little bit quickly. I don't expect you to know all of these things, but basically methotrexate works as a inhibitor of dihydrofolate to tetrahydrofolate, so dihydrofolate reductase enzyme. That's one step. It can also be important in terms of extracellular release of adenosine, which also has an anti-inflammatory properties. And it is important in transmethylation reaction inhibition, and it also inhibits, it affects the thymidylate synthase pathway as well, all of which basically inhibit purine de novo synthesis and inhibit cell replication and DNA synthesis and subsequently transcription and translation. So the pharmacokinetics, typically we give orally or subcutaneously, and it's a slower acting agent, tends to last long, and so it's given weekly. It takes up to 3 to 6 months, really 6 months, to have full intraocular effect. Level 2 data and now level 1 data that I alluded to earlier shows that, in the site data, there was 2/3 of patients had no inflammation at 1 year, and 58% were able to reduce their prednisone doses to less than 10 milligrams daily. And now we have additional data from a randomized clinical trial that has shown that methotrexate is probably a little bit more effective than mycophenolate. But again, the choice of agents is really based on an individual by individual basis. This is not nobody's going to criticize you if you use mycophenolate over methotrexate. So those two agents, methotrexate probably is a little bit more effective in controlling uveitis and being able to allow the taper of oral prednisone compared to mycophenolate itself. There are no long-term increased risk of neoplasia or secondary cancers with methotrexate, but you can develop liver function enzyme elevation with treatment that needs to be monitored in children, especially. And with long-term use, you can develop cirrhosis with high-dose methotrexate if you don't follow the liver enzymes carefully. And you can also develop secondary pulmonary fibrosis, which is a rare complication of methotrexate, sometimes seen in chemotherapy for cancers when high-dose methotrexate is used. You prevent complications by avoiding alcohol, avoiding other medicines that affect the liver, appropriate contraception in women of childbearing age and men of childbearing age also, and of course, use of folic acid supplementation for citravorum rescue. Typically, folic acid of 1 to 2 milligrams per day is given to avoid serious side effects like lethargy, generalized kind of malaise, and stomach pain, those types of side effects that are very common and fatigue that are common with methotrexate. Imuran is it inhibits de novo purine synthesis by again affecting the thiopurine methyltransferase enzyme. When you use this medication, you incorporate abnormal purine analogs into the DNA that results in stopping of DNA replication, and subsequently cell division is stopped. So it is, again, we discussed the TPMT deficiency. Usually I use 100 to 200 milligrams per day is the typical dose of Imuran, and we reduce the doses if the patient has known heterozygous TPMT deficiency. With homozygous TPMT deficiency, I don't use it at all. It's very rare, but I don't use Imuran at all. Again, the site data is shows some definite efficacy for this agent, and 62% had no inflammation after 1 year of Imuran use on the site study, and 47% were able to reduce their prednisone below 10 milligrams daily maintenance. Leukopenia, elevation liver function tests are complications. Mycophenolate Morphotyl is a inosine monophosphate dehydrogenase inhibitor. Again, it is a purine analog, its effects are that it inhibits purine synthesis and DNA synthesis ultimately. And here you have the dosing is usually 1,000 to 1,500 milligrams twice daily. And patients typically are going to be complaining of gastrointestinal disturbances if they don't take the medicine properly. Unlike prednisone, mycophenolate has to be given 2 to 3 hours prior to or after food on an empty stomach. That's very important. GI disturbances like diarrhea and constipation and nausea are very common and account for the most common side effects that require discontinuation of therapy. So I really make sure I drive home the point that they need to take this medicine on an empty stomach. And you can develop leukopenia. There is some increased risk in the rheumatologic literature of lymphoma or leukemia, and progressive multifocal leukoencephalopathy is an idiosyncratic reaction, but that has been reported with CellCept. There is substantial level 1 now evidence, as well as level 2 evidence from the site data to suggest that there is substantial positive effect from the use of mycophenolate in the control of inflammation. As I mentioned earlier, the most recent study looking at methotrexate versus mycophenolate shows that methotrexate may be slightly more effective in the treatment of non-infectious uveitis and allowing a great ability to reduce prednisone dosage and have better long-term control. And so there's good data to suggest that, however, that mycophenolate is still effective and still a good choice of an anti-metabolite. Calcineurin inhibitors work differently. They do affect the translation transcription of IL-2. And they are considered IL-2 inhibitors through a primary pathway of inhibiting calcineurin, which is which inhibits NF-AT dephosphorylation, and then that particular nuclear factor is then important in IL-2 gene synthesis, so it can impact and cause reduction of IL-2 release, which is IL-2 is, of course, is a very important cytokine for T helper cell proliferation. And so this is how the cyclosporin is a byproduct of a fungus, was discovered accidentally, and it's a terrific agent, really is very highly useful in organ transplant patients. And now it's been replaced for the most part by tacrolimus, which works in a similar mechanism. The dosage of cyclosporin is 2 to 5 milligrams per kilogram per day. When it's used in combination with other anti-metabolites, for example, it's used at a lower dosage, usually 2.5 milligrams per kilogram per day. And again, I typically just follow renal functions on cyclosporin as well as liver function tests. We used to monitor trough levels of cyclosporin, which were very difficult to do using a radioimmunoassay. That isn't necessary anymore. It's found to be just as effective to monitor renal functions in those patients rather than trough levels. Tacrolimus is a more potent agent, and you can use a lower dose of 0.1 to 0.15 milligrams per kilogram per day. I have very little experience with tacrolimus. I have some experience with cyclosporin, but I don't use cyclosporin very much anymore. There is modest efficacy and good level 1 evidence of its use in organ transplantation. The site data is good level 2 evidence to suggest that that at 1 year, more than half the patients do have no inflammation on this agent. It is difficult to wean patients off of cyclosporin. It's almost as dose-dependent long-term use as prednisone is. So that's another reason I don't like to use it. And there's lots of complications that occur with hypertension, renal function problems with higher doses, hirsutism, gingival hyperplasia, trembling, paresthesias. There are neurologic complications of it. So I like to avoid this agent. In really severe cases of systemic vasculitis and necrotizing scleritis, I will use alkylating agents such as cyclophosphamide. These are typically or chlorambucil. Chlorambucil is also used in very profound, severe uveitis that has not been responsive to anything else. In these situations, the efficacy of these agents is based on the fact that they actually cause alkylation and prevent DNA cross-linking and ultimately, cause DNA cross-linking and ultimately cause cell death. So there are toxic metabolites of cytoxin or cyclophosphamide, which is acrolein. Acrolein can cause hemorrhagic cystitis in the bladder. And so you have to make sure that patients who are being treated with Cytoxan intravenously or orally receive at very substantial fluid hydration prior to and during therapy. Orally, Cytoxan is given at 100 to 150 milligrams daily, maximum of 200 milligrams daily, with a maximum cumulative dose of 35 grams, at which point I stop. Typically, that takes about 6 months to achieve. IV pulse therapy can be given monthly for 6 to 12 months as well. I know some folks in India, some of the Europeans do use this in the hospital setting. Again, this is done through an oncologist. Highly effective agents in terms of level 2 evidence from the site studies for ocular cicatricial pemphigoid and systemic vasculitis shows that more than 3/4 of patients will have no inflammation within a year, and most patients are able to reduce their prednisone dependency. Chlorambucil is a much slower acting agent, but we can use short-term high-dose therapy for 3 to 6 months. That's highly effective. And I've used this on a couple of very recalcitrant patients in the last couple of years, even 2 actually during the pandemic, and who did very, very well. But you have to be very careful with these alkylating agents because of opportunistic infection risk. So Bactrim is usually given daily as prophylaxis for pneumocystis. You have to watch for cyclophosphamide-induced hemorrhagic cystitis and maintain adequate hydration, as I mentioned. Neoplastic risk, you need to monitor CBC and liver function tests very carefully, and sometimes weekly, particularly with high-dose chlorambucil therapy. That's why you need to have an oncologist involved in the care of these types of patients where you're considering these agents. The patients can develop severe gonadal suppression, permanent sterility with these agents as well. When we've failed with anti-metabolites and or calcineurin inhibitors, we often go to biologic response modifiers even before we consider alkylating agents. And biologic response modifiers typically are done with the help of a rheumatologist, given with the help of a rheumatologist, although now with the approval of Humira for primary non-infectious intermediate, posterior, and pan-uveitis, we have been able to prescribe this ourselves, but with caution. There are some pre-procedure things that you need to do, prescription things that you need to do to evaluate the patient, such as making sure that they have a hepatitis screen, making sure they don't have active or chronic active hepatitis C or hepatitis B, and then make sure that they do not have HIV, of course, make sure that they do not have a history of multiple sclerosis, congestive heart failure, underlying history of lupus, because these agents can also induce lupus-like syndromes. All of these need to be considered. These are not off-label for ocular disease anymore. That slide needs to be changed. I apologize. I thought I got that out of there because of the visual studies, particularly for Humira. But you got to make sure that you're not dealing with an infectious condition. And finally, you've got to make sure that the patient doesn't have TB or other fungal illnesses like histoplasmosis, okay? So if the patient has latent TB or a history of TB, that kind of thing, you have to make sure that they've been adequately treated and that's been assessed by an infectious disease specialist before you start biologic response modifiers. There are many, many, many biologic response modifiers that are now available. Many of them are monoclonal antibodies. If they say MAB at the end, that's what it means. The CEPT are usually receptor analogs. And then the PEGALs are usually pegylated polyethylene glycol conjugates of antibodies are also being utilized. So the naming of these agents are based on their chemical structure and how they're engineered. And really, there's numerous clinical trials now of showing that there have been efficacy in the use of these tnf-alpha inhibitors. How does tnf-alpha inhibitors work? They really do inhibit at a very high level the induction of IL-1 and many of the pro-inflammatory cytokine releases from inflammatory cells, including the CD4 helper cells, T helper cells, as well as macrophages. So they work at the antigen-presenting cell level, the post-antigen presenting cell activated macrophage level, as well as at the T helper cell level in terms of inhibiting inflammatory disease. Infliximab will bind membrane-bound TNF-alpha and also will the soluble TNF-alpha is bound by infliximab. Infliximab is a chimeric antibody. It has a murine component, that's the variable region, and a human IgG FC component, whereas adalimumab is again a monoclonal antibody that is completely humanized, and etanercept, which we typically don't use primarily for the treatment of uveitis, and in fact, etanercept has a clouded history of potentially being a cause of de novo uveitis in patients who don't have a history of uveitis. We avoid it, but it's a receptor analog. It has a human FC component and a human kind of a chain of TNF receptor chain that kind of binds solubilized TNF-alpha. Etanercept is no better than placebo for the treatment of uveitis. We have level 1 evidence of that. So infliximab, there's level 2 evidence, and there's strong evidence for use in explosive onset Behçet disease. Adalimumab now has level 1 evidence for the treatment and efficacy of non-infectious intermediate posterior and panuveitis. There is evidence for some of these other ones, but it's weak. Certolizumab and golimumab are not agents that we typically use for the treatment of uveitis. They may be used for other autoimmune diseases. Complications include hypersensitivity reactions and infusion reactions with use of with infliximab, but you can have exacerbation of demyelinating disease, congestive heart failure, exacerbation of TB, drug-induced lupus, and secondary neoplasia and heart failure. All of these are potential risks of TNF-alpha inhibitors. Those are important things for you to remember. Adalimumab in particular, I'm going to cover because we use this frequently as in my experience as a third-line agent, occasionally as a second-line agent for the treatment of uveitis. They have compared, so Visual 1 and Visual 2 studies showed that adalimumab increases the interval to the treatment failure from 13 to 24 weeks. It increases the interval of flare from 4.8 months to 10 months as oral corticosteroid doses are tapered, and reduces the risk of vision loss. FDA approved this drug in 2016 for non-infectious intermediate posterior uveitis and panuveitis. These are important. Visual 1 and Visual 2 trials are important. They were published in Lancet and New England Journal of Medicine, so that tells you the level of import of these of the study findings. So the hazard ratio treatment to the time of treatment failure between adalimumab versus placebo is 0.5. Therefore, the risk to fail was about 50% for adalimumab compared with the standard of care therapy and placebo with steroids. So the median time to treatment failure was prolonged by 87%, as I said, up to 24 weeks as steroids are tapered. So this is a remarkable efficacy. We know how well it works. Is it a cure? No, but it's extremely effective in controlling inflammation. So it really significantly reduced worsening of AC cell grade and reduced development of new lesions as corticosteroids were tapered. And the primary endpoint, time to treatment failure, again, the median time to treatment failure was 8.3 months for the placebo, but was not estimable with adalimumab, as fewer as half of the ADA treated patients, adalimumab treated patients, experienced treatment failure. So this is a remarkably effective thing. This trial is ongoing, so you'll see from additional information here published here soon if it's not already been published. So there is definitely efficacy in use of these medications. And compared to placebo, adalimumab is very, very effective. So in patients with active non-infectious uveitis, adalimumab significantly lowered the risk of uveitic flare as the prednisone is tapered or best-corrected visual acuity loss. And patients on adalimumab had a lower risk to fail, and fewer criteria for treatment failure were met. And worsening of AC cell grade vitreous haze and best-corrected visual acuity from best 8 was achieved, as well as occurrence of new lesions was reduced with adalimumab compared to placebo. So it was highly effective compared to placebo with just steroid taper. Adverse events data were similar between placebo and adalimumab groups. And there was the safety profile was very well compatible with what was already known about the safety profile of adalimumab, and the FDA approved it across these indications for uveitis. There are numerous secondary endpoints to the study. I won't go into the details of it. Needless to say that even the secondary endpoints suggested that TNF-alpha inhibitors were very highly effective compared to placebo. Rituxan is used in very severe, in selected cases of inflammatory disease, particularly in the management of GPA, granulomatosis, polyangiitis, and systemic vasculitis for severe and rapid control of disease. This is like giving a bone marrow transplant with an IV infusion. So Rituxan knocks out all of the CD20 positive B lymphocytes and really has a profound lymphopenic effect and really reduces inflammation in patients with vasculitis. It's also very effective in the treatment of primary intraocular lymphoma as an intravitreal agent as well as a systemic agent. And so this is where it's very useful. Refractory scleritis associated with systemic vasculitis or systemic vascular disease in general. And we can also use it for selected cases of OCP, severe orbital inflammation, and pediatric uveitis. There can be profound lymphopenia, infusion reactions can occur, and hypersensitivity reactions can occur. I have a few questions, and then I'll try to wrap things up. I do have some cases. It's going to go on. This is a very lengthy lecture. If you want me to stop because it's getting late in the day, I can certainly do that. I appreciate your attention, but we'll do these questions quickly. Which of the following immunosuppressive agents is used to treat ocular inflammatory disease most clearly associated with increased risk of malignancy? Cyclosporin, azathioprine, methotrexate, or cyclophosphamide? Okay, so yes, cyclophosphamide, because it's an alkylating agent, especially after 35-gram cumulative dose, you're going to increase the risk of malignancy. Next, the daily dosage of should be adjusted based on which of the following laboratory tests of cyclosporin: hematocrit, platelet count, creatinine, or glucose. Yeah, exactly. So renal function testing is very important. So creatinine level is what you need to check in patients who are given systemic cyclosporins because of its potential toxicity profile. Next, what does monoclonal antibody infliximab target? Let's see if you're paying attention. Interleukin-2, cyclooxygenase, choroidal melanoma cells, tumor necrosis factor alpha. So this is an easy question, right? Everybody should get this one. Yeah, so it targets TNF-alpha. It's a TNF-alpha inhibitor, Remicade or infliximab. We talked about adalimumab and infliximab. Those are the two agents that are most commonly used in the treatment of uveitis as second or third line agents. Which of the following is not a contraindication for TNF-alpha inhibitors? So multiple sclerosis, uveitis in a child younger than 10 years of age, TB, or heart failure, which is not a contraindication. So where would you use TNF-alpha inhibitor? All right, so the answer is yes. So, so TNF-alpha inhibitors, if they can cause exacerbation of underlying multiple sclerosis or cause de novo demyelinating disease. They can cause worsening or exacerbation of heart failure. They can cause a reactivation of latent tuberculosis. So those are all contraindications. But we use Remicade and Humira in the treatment of uveitis in children very commonly. So that's not a contraindication. That's the answer. Most common side effect of mycophenolate morphotyl is gastrointestinal disturbances like diarrhea, myelosuppression, elevation of liver function tests, or nephrotoxicity. The most common side effect of mycophenolate, it was in a slide in yellow, 18% developed this side effect in clinical studies. Yeah. So my diarrhea or gastrointestinal side effects are the most common. That's correct. Okay. So let's see. I think we're coming down to the end here. Which anti-metabolite has the most rapid onset of therapeutic immunosuppressive activity? Methotrexate, chlorambucil, mycophenolate, or azathioprine? Just a hint, methotrexate and azathioprine take 6 months to be most effective. So the answer, this is a tough one. So methotrexate takes very long. It's not the most rapid. Mycophenolate is the most rapid. So mycophenolate, in my experience, within a couple of months, we can see its anti-inflammatory effects in the eye, 2 to 3 months. Methotrexate longer. Chlorambucil is a tricky one because if you use high-dose short-term therapy, you may see an efficacy of inflammatory control within the first 2 to 3 months, but it's variable. It's not in its effect. So I would have accepted either chlorambucil or mycophenolate, high-dose chlorambucil or mycophenolate as the answer. But mycophenolate, I think, is the answer in that slide. There are many other biologic response modifiers. Tocilizumab is used as another useful agent for when our traditional TNF-alpha inhibitors fail. And I have had some experience with the use of that agent. Some of these other agents, such as IL-6 inhibitors and IL-17, TH17 inhibitors, I have less experience with. Many of these are still undergoing clinical trials. And they're used for treatment of other autoimmune conditions. Secukinumab is an IL-17 inhibitor that it has sustained inhibitory activity for 2 months after treatment. This is something that is being evaluated still and may have some role along with tocilizumab in the treatment of ocular inflammation. So, the goal of treatment for uveitis is start with corticosteroids, topical, regional if it's unilateral, and then orals if it's bilateral at high doses and gradually taper very slowly. And if they can't be tapered to reasonable dosage to control the inflammation with chronic disease, then you have to institute immunomodulatory therapy. In the most severe cases, especially in severe chronic disease, you need to institute immunosuppressive therapy sooner. Immunosuppressive therapy and or steroid therapy requires vigilance and close monitoring, and therapy may be required for many years. We know when to start therapy, mostly, but we don't know when to stop therapy. When do you predict that a patient has achieved durable remission? We don't know. So this is I'm going to go through these cases very quickly. This is a patient who presents with severe pain and has had flattening of her nasal cartilage and auricular cartilage pain. So this is a case of the diagnosis. You see these white areas is where the pain is most intense. The entire eye is very injected. This patient also has significant joint pain, but has noticed her bridge of her nose is flattened, and she has pain in her ear cartilage. So this is relapsing polychondritis associated with necrotizing scleritis. The treatment of this is rapid. We use corticosteroids with rapid induction of immunosuppressive therapy. Usually with this, we use alkylating agents and or nowadays Rituxan, which is associated with a good response to systemic vasculitis and necrotizing scleritis. This is a patient who presents with acute red, photophobic, painful eye. Vision is count fingers with the plasmoid aqueous and a small hypopion, and he has this psoriasis. So the diagnosis here is HLA-B27 positive, acute, hyperacute anterior uveitis with plasmoid aqueous and hypopion. This patient should also be tested for syphilis, and it's negative. In this case, we started aggressive topical steroid therapy and also instituted oral steroids because of the severity of the ocular inflammation. And we tapered the oral steroids over 3 months and the topical steroids over 16 weeks. And was evaluated by rheumatology for the further treatment of his systemic psoriasis, psoriatic arthritis. So this patient can be treated with corticosteroids alone, and with heavy doses can be controlled without necessarily using immunosuppressives for the treatment of uveitis. Inadequate control of inflammation in this kind of a case can result in chronic disease, at which point they become recalcitrant to steroid therapy, and which point they will require immunosuppression. Also, aggressive use of atropine in a case like this in the early cases to cycloplege and dilate the pupil is important. And once the inflammation is better controlled, we can switch from atropine to cyclopentolate, which is a milder mydriatic agent. So frequent topical steroid drops, tapered very slowly. Periocular steroids can also be done if it's unilateral. Oral corticosteroids can be done. Watch out for recurrent and chronic disease. This is a patient who has presented like this with poor vision in both eyes, and she was 5 years old. This is a tragic case. This is a patient who had calcific band keratopathy, chronic posterior synechia. She also had some mild joint pains in her knee and ankle. So she has chronic anterior uveitis associated with juvenile idiopathic arthritis. She was ANA positive and also had poly or oligoarticular disease. We've ruled out infectious causes, and the patient was started on topical steroids and cycloplegics, but rapidly was started on immunosuppressive therapy with methotrexate and tnf-alpha inhibitors. So here's another patient with a classic disease. This is a patient, when you look at it, you know what the diagnosis is, right? This is a patient who has birdshot uveitis, birdshot retinochoroiditis, disc edema, multiple birdshot-like lesions, vascular leakage and CME, and disc staining. This patient can be treated initially with oral corticosteroids, but most, since they have bilateral disease, will require long-term immunosuppression. And we can use anti-metabolites with or without TNF-alpha inhibitors. Some folks can feel that management of these patients can be done with Retroseptal implantation, which is not unreasonable, but because it's a lifelong disease, these implants last 3 years, they need to be replaced every 3 years. And 100% will develop cataracts with Retroseptal, and 40% may develop glaucoma requiring surgery. Here is a patient who has shortness of breath, weight loss, and presents with these conjunctival nodules. And there's the biopsy of the nodule and this granulomatous inflammation in the anterior chamber with mutton fat KPs. And the posterior segment shows Toss to Bougie perivascular infiltrates and vitreous snowball opacities and a severe panuveitis. The diagnosis, this is pretty easy. We know I'm giving you everything. The diagnosis is sarcoid uveitis. Sarcoid, in my experience, tends to be exquisitely steroid responsive, and so can be managed often with corticosteroids alone. Occasionally, when that fails, immunosuppressive therapy may be necessary. This is a classic presentation of a patient who has an ephemeral hyphopion, a hyphopion that goes away if they shake their head, oral aphthous ulcers, and presentation with vasculitis, retinal vasculitis in one eye and retinal hemorrhages affecting the veins and arteries, and also in the fellow eye, this type of appearance with almost a retinitis type of appearance. So this patient has what syndrome? Everybody probably knows this. This is Behçet's disease. This patient requires anti-TNF therapy because of the retinal vasculitis and needs to be treated aggressively with long-term immunosuppression as well. Topical corticosteroids and regional steroids can also be utilized for acute control. Next, this is a patient who's HIV positive who presents with sudden onset of floaters and severe vision loss, severe peripheral visual field loss. And we know that he has AIDS, actually. CD4 count is 0. So this patient has, by definition, this patient probably has infectious uveitis. So this is not a patient I would recommend starting steroids on, obviously. This is not a patient that we can treat only with topical steroids, et cetera, to treat their inflammation. The eye is white. There's not much cell in the anterior chamber because CD4 counts are low. So the diagnosis is made based on aqueous PCR. I would do an aqueous tap, send for PCR evaluation for viruses. We find that he had varicella zoster virus. I would start him empirically on systemic antivirals. And then I would avoid oral steroids if they have AIDS. If they don't have AIDS and they have necrotizing herpetic retinitis, you can add oral steroids when they have antiviral cover to control inflammation. So this is handled very differently. So here you see that's infectious. You treat the infectious condition with anti-infective agents, and then you can use the steroids to control inflammation if their immune system is normal. Here's a patient who is HIV positive with CD4 counts of 10, who presents with sudden vision loss in the left eye and floaters. So this patient has frosted branch angiitis from cytomegalovirus. This patient is likely HIV positive and or has iatrogenic immune compromise. PCR testing will be necessary to confirm that it's cytomegalovirus. Intravenous and intravitreal antivirals may be recommended until immune reconstitution, and avoid systemic and regional steroids in these patients. So those are the cases that I have. I'm going to look at, it looks like there are 30 Q&As. Let me see if I can rapidly go through the question and answers. Immunomodulatory therapy in VKH is started relatively quickly, especially with severe presentation. I usually start them on high-dose oral corticosteroids, and within a couple of weeks, we'll start them on an anti-metabolite such as methotrexate or mycophenolate. Same day with tabprednisone. Okay, according to Professor Jabs, a dose of 7.5 milligrams considered safe dose with no side effects. What are your thoughts? Yes, so Dr. Jabs is, I have a great respect for Doug. And he's a fantastic and one of the fathers of modern uveitis. I consider him, even though he's not that old, he's terrific. So I have followed many of his, advice and approaches, and I agree. I think really my approach is to try to get it below 7.5 if I can. So anything below 10, especially 7.5 or less, I consider a relatively safe dose. And long-term, if you look at the risks of long-term complications at 10 milligrams versus 7.5, there's a substantial reduction at 7.5 or 5 milligrams compared to 10. Our adrenal gland makes an equivalent of about 5 milligrams of prednisone daily. So when we get down to that level, the patient may become still steroid dependent, but it's a safe level and unlikely to cause long-term issues such as severe osteoporosis, aseptic necrosis, worsening of diabetes and hypertension. Those kinds of things are less likely to happen. Reduce side effects of, next question is reduce side effects of anti-TNF we combine with methotrexate, but if not available methotrexate, can I use anti-metabolite or cyclosporin instead of methotrexate? You can use other anti-metabolites if methotrexate is not available. I have used Cellcept with tnf-alpha inhibitors as well. You can use cyclosporin or tacrolimus. I have less experience with that in the face of TNF inhibitors. Because of the neurologic complications of cyclosporin, I tend to avoid it, especially with TNF-alpha inhibitors, because if there's a risk of demyelinating disease and then you have other neurologic issues that you can't tell are side effects of TNF, of the cyclosporin, it just becomes too confusing. Is there a role of sulfasalazine in uveitis? Not in my experience. I think it's great for the treatment and management of symptomatic inflammatory bowel disease and maybe inflammatory bowel disease associated arthritis, but it does very little, I think, for the management of uveitis. I have seen some rheumatologists try to use that, but it doesn't make any difference in terms of, in my experience, in terms of uveitis recurrences. There are some publications about it. I think Dr. Foster has written about its use, but I think it has some limited value. For which immunomodulatory drug is live vaccine a contraindication? Really, I would avoid live viral vaccine and any immunomodulatory therapy. It's just, I would avoid it. Live viruses potentially carry substantial risk of causing some severe problems. So always choose to go with a killed or attenuated non-live viral vaccine. How to differentiate old and new vitreous cells, how long the cells can go away. Yeah, this is a difficult thing. Most old vitreous cells become pygnotic and may become pigmented over time, then they become suspended in the vitreous, in the formed vitreous, and they take a long time to go away, sometimes years. And as long as they're not, you have to be really careful in terms of deciding how effective it is when you're looking at the vitreous inflammation. There isn't SUN criteria, standardization uveitis nomenclature criteria for determining what is the number of vitreous cells that you look at in the slit lamp. We all have our own way of doing it. Vitreous haze, I think, is a much more gross measure because many patients who have vitritis may not have much haze, but we still treat the vitritis. In the site study, methotrexate is most effective than other metabolites in posterior uveitis. May you give an example of posterior uveitis when methotrexate more effective than other antimetabolites? I know when associated with scleritis and methotrexate may be more effective, but in a case of posterior uveitis, well, for example, if you have somebody who has sarcoid uveitis who's steroid resistant or requires higher doses of corticosteroids, that may be a case where I would consider methotrexate use. You can also use it as a adjunctive agent in somebody who has serpiginous choroiditis. I have done that. I use it in birdshot as posterior uveitis and may be effective for birdshot as a primary a second line therapy. So those are the situations where we can use it. And the newest data suggests that methotrexate probably is a little bit more effective than Cellcept, but again, doesn't mean you're wrong to use Cellcept or mycophenolate. Okay, please don't get me wrong. I'm just telling you that the data is highly suggestive that methotrexate is effective, and there is synergy of methotrexate with TNF-alpha inhibitors. That's why we use it together. I think the synergy of the anti-inflammatory effects is fairly significant. In children, especially, we see it. When IMT is used in pregnancy with harmful in breastfeeding, yes. So we talked about Imuran being safe, TNF-alpha inhibitors being safe. With breastfeeding, I believe that I would avoid any immunomodulatory therapy if the person is actively breastfeeding. But I do think that TNF-alpha inhibitors are probably relatively safe in breastfeeding. These are things that should be discussed with the obstetrician or with the pediatrician, neonatologist. When you use phenylephrine, can you use phenylephrine as a dilating the pupil? Maybe. We use it during cataract surgery and in the operating room, but never alone because its efficacy is very short-lived. It lasts only a few hours, and it's not it doesn't result in complete cycloplegia. It's a good at dilating, but not cycloplegia. How do you treat posterior uveitis in patients with adrenal insufficiency? Well, in adrenal insufficiency, obviously, if their posterior uveitis is non-infectious, and that's very important to make sure that it's non-infectious, and you treat it the same way. They have adrenal insufficiency, they're not making any hydrocortisone at all, or cortisone-related derivatives, cortisol-related derivatives, so they need corticosteroids. And they may need immunosuppression based on how they respond. Do we need drug level monitoring in uveitis? No, generally not. We don't monitor Humira levels, although we do monitor antibodies, autoantibodies against Humira. Autoantibodies against other monoclonal antibody drugs can be checked. It's a very expensive test, but can be useful in patients who we feel have achieved non-effectiveness with the drug. Because remember, 20% of us have autoantibodies already in our body, so that we can mount an immune response against monoclonal antibodies that are given for therapy. So this is interesting, and I think it's a great question. So, but we don't need to monitor drug levels of cyclosporin. You can just monitor serum creatinine usually. May you give a posterior example when methotrexate most effective? Well, we already talked about that. It's all, the choice of immunosuppressive agent is still, in my mind, one where after 30 years of doing this, I can tell you that I don't know that I can tell you, whoa, this drug is going to work great with this. There are some exceptions. For example, retinal vasculitis or vasculitis. I tend to find that if it's severe systemic vasculitis, alkylating agents and or Rituxan are going to be very useful with long-term use of agents like Imuran or mycophenolate. Mycophenolate is good for isolated retinal vasculitis. It's all kind of lodoprednol preferred. No, I don't use lodoprednol. I usually use fluorometholone if I'm worried about intraocular pressure. Can we combine more than 2 IMTs? Yes, you can. But I typically avoid using the same class. So, for example, I'd avoid using 2 anti-metabolites together, although sometimes you don't have a choice. But typically, if I'm using methotrexate or mycophenolate, then I would add a calcineurin inhibitor at low doses, or add TNF-alpha inhibitor. And then you can, and of course, yes, you may have to use steroid with it. So again, you have steroids that are using and tapering, and then adding these immunosuppressives as you're tapering the steroids, and you're trying to find the lowest dose of steroid to keep the inflammation controlled while continuing the immunosuppressive agent. Are topical cyclosporin drops effective in parasplenitis and posterior uveitis? Not in my experience, no. If the patient has non-response to high-dose steroids, does it mean that the patient has autoimmune disease that is useless to try IMT? So listen, if the patient has autoimmune disease and you know it's not infectious and they're not responding to steroid, there are two possibilities. You've missed an infection. You're dealing with a neoplastic condition that's not uveitis, but a masquerade syndrome. And thirdly, yeah, it's a really bad uveitis, and you're going to have to use something like Remicade or some TNF-alpha inhibitor with the help of a rheumatologist. So I think these are things to kind of keep in the back of the mind. If traditional treatments, steroids are effective in 95% of patients. So if you're seeing no effect or it's getting worse on steroid, then you have a problem. You made a wrong diagnosis, or you've gone down the pathway where you may be dealing with something that's looking like non-infectious, but it's actually infectious, or it may be neoplastic. So keep that in mind. Remember that the diagnosis of uveitis, the etiology is an evolutionary process. It's not something you can make immediately, just looking at it. It's rare. I mean, sometimes we can. Obviously, the slides that I showed you were meant to be that way. Till now, no sustained release IMT. That's right. Only the steroid. I wish there was. That would be a great thing. People are working on that. Intravitreal sirolimus. But and is the liver function test elevated in azathioprine? Can I shift to another anti-metabolites, or better to go to other group? Well, it depends. If the patient is on azathioprine and they have TPMT deficiency, you may be okay with methotrexate because that won't be affected by TPMT deficiency. So I mean, you'll be able to switch to another anti-metabolite or to Cellcept. So that's one thing. So you may want to check a TPMT level if their liver function tests are elevated to determine if there is thiopurine methyltransferase, heterozygous or homozygous deficiency, enzyme deficiency or aberrancy. So that would be important. What would you use in a young female with chronic VKH pregnant with a baseline prednisone 10 milligrams, doesn't tolerate more and not tolerant of azathioprine, still minimally active? Probably Humira would be my choice for that one. I wish you had 2 hours to discuss. Okay, so I'm going to 2 hours, it looks like. If a patient is stable on steroid 5 milligrams in IMT and we want to stop gradually all medicines, which is first to stop, the medicine or the IMT? This is an excellent question. I would try to reduce the steroid, not stop it at 5, but go down by 1 milligram at a time. So I would go for 4 milligrams a day. 3 milligrams a day, very slowly over the course of several months. And then if they're stable at that, then I'll go to every other day at 1 milligram or once a week at 1 milligram of prednisone, and then gradually taper off that first, and then consider tapering the immunosuppressive therapy. If anti-TNF failure, do we need to do anti-TNF antibody test? Yeah, not in all cases, but you should consider it. I think it's especially if you've been using it for a while and the patient becomes recalcitrant, you need to consider it. So I have several patients who have failed Humira, who are JIA patients, who I now have on tocilizumab. Tocilizumab is rapidly becoming a third-line preferred agent as an anti-TNF agent that's newer. It was originally kind of touted to be effective for giant cell arteritis and other things, but I think it really has a niche role as an agent for recalcitrant uveitis. So that's something that your rheumatologist would need to discuss. So I usually with VKH, if methotrexate doesn't work, I often will add TNF-alpha inhibitors. Sarcoidosis, Behçet's, TB, these are all questions that they had. I think people are answering the questions. Let's see. Is there a role for vitrectomy in chronic uveitis with vitreous opacities? Yes. Patients who have toxoplasmosis with severe uveitis opacities or vitreous opacities will benefit from vitrectomy. You have to be careful about development of secondary retinal detachment during surgery. The second issue is parasplenitis or intermediate uveitis that has significant vitreous opacities that remain. There may be value for doing vitrectomy combined with endolaser and panretinal photocoagulation treatment in these cases. And how do you treat concurrent macular edema in a chronic uveitis who's already on oral prednisone and immunosuppressive therapy? Sometimes use of intravitreal dexamethasone implant or intravitreal corticosteroid therapy in a non-infectious uveitis can be very effective for the treatment of macular edema. That's what they're there for. And even the fluocinolone implant, the YUTIQ implant, can be effective for macular edema that's residual. So that's another treatment option that you have. Thank you, everybody. This is thank you for your attention. It's an hour and 45 minutes, is a record. You guys are wonderful for hanging on. I hope you have a wonderful rest of your day, and thank you for your attention. Look forward to maybe sometime next year giving some additional presentation. Good luck. Bye-bye.